I'm going to be doing a pediatric induction and emergence sequence, so I'm going to bring my patient back to the OR, place him on the table. I'm going to grab a pulse oximeter, try and put that on my patient at the very least, if not other monitors. I know that pediatric patients have a larger occiput, so that's going to place them in a more sniffing position and can make their airway more anterior. So I can place a rolled towel underneath their shoulders if it optimizes my airway. I have my patient's kilograms written down and all my doses of meds drawn up. I'm going to prime my circuit and grab the right size mask for my patient. Prime my circuit by turning up my nitrous to 7, which turns my oxygen up to 3. I can turn my SIVO to 2, secure the mask to my patient with the EC clamp. If the patient's being cooperative, I can increase my SIVO in increments of 2 all the way up to 8. If they're not being cooperative and not tolerating it, I can just go all the way up to 8. I'm going to assess with ventilations if necessary, if they're obstructing, and I'm going to look at my end-tidal CO2 and my tidal volume on my monitor to make sure they're ventilating. The patient's going to go through stage 2, or risk of this is laryngospasm. They're going to have involuntary muscle movements, so I have an assistant holding down the limbs. They could be breath holding and also have disconjugated gaze. Once they enter stage 3, I'm going to turn my nitrous off, my SIVO down to 6. We're going to start an IV, either I will or my assistant. I have my induction meds drawn up: propofol, 3 milligrams per kilogram, ketorolac, 0.5 milligrams per kilogram, fentanyl, 1 mic per kilogram, dexamethasone, 0.5 milligrams per kilogram, and ondansetron, 50 mics per kilogram. I'm going to give those. I'll assist with ventilations as my patient goes apneic. And we can start thinking about intubation. So I have all my supplies lined up on my cart over here. I have the tube I want and the size up, size down, as well as my OPAs and blades. For tube size, I can do 16 plus H divided by 4, tube depth 12 plus H divided by 2, or 1 to 2 centimeters past the cords. For blades, I have a Mac blade, curved blade, size 2, and this is going to be placed in the right side of the mouth. Sweep more left, being in the vallecula, going towards the corner of the room. Pediatric patients have a stiff and long epiglottis, so usually the Miller blade is the preferred blade. It's a straight blade, size 1. This is going to be placed right side or midline of the mouth, under the epiglottis. Insert my tube 1 to 2 centimeters past the cords. Connect my circuit. Give it a couple breaths. I see mist in my tube. I'm looking at my end-tidal CO2 and my sets are maintaining. I'm looking for equal and bilateral chest rise and fall, and I'm going to auscultate equal breath sounds. If everything looks good to me, I can tape my tube and document at the teeth. I'm going to maintain my patient throughout the procedure, and we can start thinking about extubation. With extubation, I can either do an awake or a deep extubation. With a deep extubation, this is going to be less stimulating, but it predisposes the patient to a laryngospasm if they have any stimuli coming through stage 2. We also risk the patient not being able to maintain their airway with an awake extubation. It's more stimulating. Kids are more at risk for intracranial hemorrhage, especially with hypertension and stimulation. So that's risk, but we know that the patient can maintain their airway. So we extubate, and if I see any signs like if I have any resistance to positive pressure ventilation, or I start seeing an end-tidal waveform that looks like a shark fin, or it goes flat, and the patient has inspiratory stridor. This can be a laryngospasm, and the risks of this are going to be light anesthesia, stage 2, noxious stimuli, reactive airway disease like asthma, recent upper respiratory infection. So the way I'm going to treat this is close my APL valve to 20, give some positive pressure ventilations, see if that helps. If not, I can reposition the airway and I can insert an OPA. The thing about OPAs is that I can accidentally obstruct more by pushing the tongue deeper, or it can worsen laryngospasm if it's too long and goes towards the back of the throat. I can try the Larson maneuver. I can then close my APL valve all the way, give and hold my breath, and that pressure is probably going to go above 20 centimeters of water, which I know at that pressure level is going to start kicking off into the stomach, so I need to just be aware about that. Complications of laryngospasm would be negative pressure pulmonary edema, cardiovascular instability and collapse. So if I have any cardiovascular involvement, I'm going to start drying up my emergency meds like succinylcholine. I'll give 2 milligrams per kilogram IV, 4 milligrams per kilogram IM, and atropine with that, 0.02 milligrams per kilogram with a minimum dose of 0.1. I can also, before I give the sucks and the atropine, I can also deepen my anesthesia by giving propofol or SIBO. This is going to break the laryngospasm. So for a bronchospasm, this is another risk. Same sort of risk factors as the laryngospasm, and this is going to manifest as inspiratory wheezes, and this is going to be the shark fin, anti-LCO2 as well, and resistance to positive pressure ventilation. The way I'm going to deal with this is turn my FiO2 up to 100%. I can also deepen anesthesia with SIBO or propofol, give positive pressure ventilation, give ketamine, methylprednisolone, 1 milligram per kilogram, albuterol, 8 to 10 puffs, and this will break the bronchospasm. I can also give lidocaine, and both laryngospasm and bronchospasm can lead to hypoxia, and if this happens, this can lead to bradycardia. The way we treat this is atropine, 0.02 milligrams per kilogram, and a minimum dose of 0.1 milligrams per kilogram. We can also do epi, 1 mic per kilogram, and follow PAL's protocol to start CPR with a heart rate less than 60.